All right. Good morning, everyone. We are going to get started in just a few minutes. However, before I get started, I would love to get to know each and every one of you. If you don't mind opening up your chat box and typing in hello and where you're from, I would absolutely love to connect with each of you. Getting ready to start in just a few minutes. Hello, everybody on YouTube as well. We are live streaming both on Zoom as well as on YouTube. So, big audience today. I'm really excited for this review. Just a couple more minutes and we will get started soon. Thanks for tuning in. All right, everyone. Well, welcome to today's session. Thank you all for showing up on time and spending your morning with me today. I do want to let you know that I did put into the chat an upcoming course, which I will be highlighting a little bit later on. But without further ado, I wanted to start out our session today by going through just some key pointers and some key introduction facts on HyGuru. And I just want to first introduce myself. If you are new, welcome to the HyGuru family. My name is Rahul. I'm currently doing my fellowship in pediatric critical care medicine, and I've been absolutely passionate about helping students just like you prepare for the USMLE. Now, a couple of things that are exceedingly important regarding HyGuru is that this resource is an evidence-based approach to USMLE preparation. I like to focus my lectures on active recall, and today I'm going to be going through a lot of the pulmonary concepts in a very question-based way. I also like focusing on integration. Today's session, we're going to be going through, ARDS, and then bam, we're going to go back to pulmonary physiology and talk about type 2 pneumocytes and surfactant. Finally, I'm very passionate about test-taking strategy, and this is something that I have cultivated with my one-on-one students as well as in my test-taking strategies course. So when I think about USMLE preparation, guys, I think about not only getting good at the content, but using test-taking strategies so that you can apply the content. I'm also really passionate about making sure that you have a peak optimal mindset as you're going through your dedicated study. This is a stressful exam. And so we need to really build mental models and wellness techniques so that you can excel on a day-to-day basis. And then finally, no USMLE preparation is complete without having a solid plan that is focused on UWorld, a solid plan that is focused on integrating questions throughout the day, and finally, mastering the concepts from the NBME. And this webinar today is geared towards mastering those concepts. I think most importantly, and as many of you know, we have over 200 people joining us today. HyGuru is just one big family, and I have been absolutely passionate about teaching live and now online to many students around the world. It's been absolutely humbling, and I hope that you can join me in this global community of lifelong learners, and the USMLE is a great opportunity for you to build your foundations as you excel into clinical medicine. So just a little bit of a background as to what inspired me to create this webinar. Well, on Reddit not too long ago, there was a thread that highlighted the top NBME concepts from all of the old as well as even now new NBMEs. And what I've been doing throughout all of my prior webinars is going through systems-based, highlighting those topics in a question-based active recall way. Many students around the world, around the country have already watched my prior reviews. And if you haven't, I do encourage you to subscribe to my YouTube channel and check out the playlist that has all of them organized for you. And finally, on my website under free resources, I have placed each of these videos in small bite-sized pieces so that you can track your progress and do some practice questions along the way. My website is hyguru.com, so make sure you check out and enroll in the free course. I have placed some physiology lectures on there, as well as lectures on acid base. So it's called the NBME Top Concepts class. It has the subheading of the Golden Style Classroom course. I called it that because it is so question-oriented, and I promise you, in 1 hour and 15 minutes, you will get the high yields from each of the systems, and that is where my passion is. So without further ado, I know we have so many people just logging in right now, but I want to ask you the most important question of the day, and that is, if you are ready to go ahead and get started with our top concepts review on respiratory, go ahead and type in yes into the chat box. All right, Santiago's ready, Jessica's ready, Kieran, Livia, oh my gosh, we have so many people joining us today. And feel free to just keep your chat box open on panelists and attendees so that you can interact and you can type out some of these answers, because there are going to be a lot of NBME style multiple choice questions as well as active recall questions. And I want this to be very, very interactive. So the more that you type, the more that you interact, the better. I want to also give you guys a disclaimer, and that is that this session is intended for 1 hour and 15 minutes of your time. I would encourage you to not passively go through this webinar. I want you to be very active in this webinar. So cut out all of the distractions. This shouldn't be a background noise. Take off your phone for a second, put it in airplane mode, put it in silent, and close all of those unnecessary tabs. I want you to stay focused and engaged for this hour and 15 minutes. And finally, please let me know if you have questions throughout the session, but most importantly, I'll be getting to all of the questions at the end where I'll be doing a live Q&A. So I am pumped for each of you to join me. Let's go through the overview of what we're going to be talking about. So the first thing that I want to go through today, guys, is going to be tackling hypoxemia. Now, hypoxemia is going to be seen in your test questions when they put a low saturation, i.e. a low pulse ox, or they give you our arterial blood gas and you see a low P(a)O2. And we're going to be going through the causes of hypoxemia, especially as it relates to the USMLE questions. Then what we'll do is we'll transition and talk a little bit about the various lung findings that you can get on physical exam and how that correlates to pathology. We'll then spend the majority of our session talking about restrictive versus obstructive lung pathologies. And guys, this is probably the highest yield portion of the lecture, so definitely stay tuned for this one. We'll end with talking about lung tumors and going through some paraneoplastic syndromes, and then we will discuss acute respiratory distress syndrome. So without further ado, let's go through our first concept, and that is going to be the AA gradient and hypoxemia. So like I mentioned, here's the test-taking strategy for recognizing hypoxemia questions on the USMLE. The USMLE will test hypoxemia by showing a low SpO2 in exam questions. And specifically, it will show a low saturation in the vital signs. Next, in the labs, you may see a low P(a)O2, which is your arterial dissolved oxygen. And a low P(a)O2 less than 60 is really going to define hypoxemia. But remember that our normal P(a)O2 should be around 100. So as you go through and look at the vital signs as well as the labs and you see hypoxemia, use this as a pertinent positive to channel your mind into the various causes that we're about to discuss. So let's first go through a GenPath tie-in, and that is talking a little bit about hypoxemia and how it relates to tissue hypoxia. So hypoxemia, like we said, it's low P(a)O2 in the body. And subsequently, remember that if you have anemia, i.e. a low oxygen in the blood, and that reaches the tissue, that causes a tissue hypoxia. And that's really important because there's a biochemical tie-in here. And that is that once you have tissue hypoxia, you transition from aerobic respiration into anaerobic metabolism. And anaerobic metabolism is defined by a presence of high lactate. In fact, the biochemistry tie-in here for you guys is to know that pyruvate essentially gets converted into lactate. And that is because you have glycolysis up here, but because you don't have oxygen, you're unable to go TCA to electron transport chain, and you get stuck in glycolysis. The pyruvate shunts to lactate, and you get a metabolic acidosis. So how do you recognize a metabolic acidosis on your USMLE questions? Well, remember that acidosis is defined by a low pH. And subsequently, a metabolic acidosis is defined by a low bicarb. Now, if in the test question, they give you a low pH and a low bicarb, you should really look for other electrolytes. Because if they give you other electrolytes, what they are testing you on is the anion gap. And remember, the anion gap is going to be your positives minus your negatives. And that's really important for you to understand. Now, lactic acidosis, go ahead and type this in the chat. Does it give you an elevated anion gap, type in up, or a normal anion gap? Go ahead and put that in the chat for me. And people are just waking up, attending here. Exactly. Up or elevated anion gap metabolic acidosis. Very important for us to know. So let's go ahead and go through this test question. A 52-year-old male is found unresponsive. His medical history is unknown. On physical exam, he is unresponsive despite sternal rub. Man, he's not waking up. He is cool. All right. His laboratory studies are notable for low pH, low P(a)O2, low bicarb, and a high CO2. Wow. Which of the following diagnoses is most likely to be seen in this patient? A, respiratory alkalosis, B, metabolic alkalosis, C, hyperoxia, or D, high lactate? Go ahead and put that into the chat right now. And yeah, we just covered this concept. So everybody in the chat is putting D. And if you put D, you're absolutely correct. High lactate. Now, what is high yield for us to know is that elevated lactate is only one of the mud piles. What are the other ones? Well, what about methanol ingestion or uremia, which is going to be seen in your dialysis patients or patients who are going to have a high uric acid burden? You're going to see DKA questions, polyethylene glycol, isoniazid or iron toxicity, ethylene glycol, and salicylates. And what's high yield for us to know for salicylates, guys, just as an aside, is that salicylate poisoning on your USMLE is going to give you a mixed acid-base disorder. And what is that acid-base disorder? They love to go for this on exams. Respiratory alkalosis, then an anion gap metabolic acidosis. Very high yield for us to know. So just like in the question, we saw low P little AO2. And what we need to do is we need to talk a little bit about hypoxemia. Hypoxemia can be stratified by understanding the AA gradient. And the AA gradient is basically what the lung does from a normal physiology standpoint. And that is take P big AO2 and turn it into P little AO2. Okay. So alveolar oxygen goes into arterial oxygen. And there are entities of hypoxemia that give you a normal AA gradient as well as an elevated AA gradient. So when we think about a normal AA gradient cause of hypoxemia, you're going to be thinking about hypoventilation and high altitude. And what's really important for us to recognize is that hypoventilation and high altitude are going to not affect the alveolar capillary membrane. That's important for us to know. When you're thinking about elevated AA gradient, which is typically above 15, when you think about elevated AA gradient causes of hypoxemia, they actually affect the pulmonary capillary interface. And causes of elevated AA gradient hypoxemia are going to be VQ mismatch, which is going to be a mismatch between ventilation and perfusion. You can easily see it like this, ventilation and perfusion. A diffusion defect, think about this membrane being very thick in purple here, or completely bypassing the lungs, as you will see in right to left shunt, which is going to be blue blood goes into the systemic circulation. So with this in mind, let's go ahead now and break this diagram down. The first cause that we are going to be talking about is hypoventilation. Now, in order for me to assess if you're paying attention, go ahead and put in the chat, is the AA gradient normal or elevated with hypoventilation? Go ahead and put that in the chat. People are putting normal, and you are absolutely correct that it is going to be absolutely normal. So let's go ahead and go through a USMLE question. You have an obese patient who presents to the emergency department after being at a party. He is somnolent and has pinpoint pupils. His respiratory rate is 8. What would be the most likely acid-base abnormality? So with pinpoint pupils, as well as a low respiratory rate, you are going to be thinking of opioid intoxication. You got it. And so opioid intoxication causes you to hypoventilate, increase your alveolar CO2, and thus you are going to have a respiratory acidosis. Now, guys, remember in your exam questions, respiratory acidosis, low pH, and a high PCO2. Very important for us to know. Now, with hypoventilation, the unique characteristic is that there's no change in the AA gradient because you're not necessarily messing with the alveolar capillary interface. I can't stress that enough. Let's contrast hypoventilation with high altitude. An athlete who trains in Colorado is going to be on day 2 found to have a respiratory rate of 22. He is training above sea level for 3 weeks, and labs at the end of his 3 weeks show an elevated hematocrit. What is the likely mechanism here? Elevated hematocrit? Am I in the right lecture? Is this heme? Well, actually, you got to understand here that when you have hypoxemia, due to high altitude, that can actually stimulate the kidneys to start secreting erythropoietin. And increased erythropoietin from the peritubular capillary cells calls on the bone marrow to start increasing reticulocyte production. And thus, you get a higher RBC mass, and you're going to have an elevated hemoglobin and hematocrit. Again, high altitude causing hypoxemia, there is no change in the AA gradient because what is affected primarily is going to be your alveolar O2. And that's really important for us to recognize. Hypoxemia in this setting causes increased synthesis of 2,3-BPG. And that's actually really important for us to know because when you have increased synthesis of 2,3-BPG, you actually have a right shift in your hemoglobin oxygen dissociation curve, and subsequently you offload oxygen from hemoglobin into the tissues. You also are going to start hyperventilating in high altitude. And we see this right here in the test question where I put the respiratory rate is slightly elevated at 22. Now, remember, this goes back to neurology and cerebral autoregulation, that in the setting of hyperventilation, you are going to decrease your PaCO2. And if you decrease your PaCO2, you can actually get vasoconstriction of the cerebral vasculature and you get decreased cerebral perfusion. And that is one of the mechanisms proposed in the setting of thinking about the symptomatology of lightheadedness. So this is from BRS Costanzo, and I do want to kind of highlight some key points. Remember that you have a decreased partial atmospheric pressure and thus decreased P big AO2 when you have high altitude. What's important for us to know is that's going to start stimulating hyperventilation. And remember that hyperventilation is going to cause you to have a respiratory alkalosis. As you drive down your CO2, your pH is going to go up. High altitude also causes hypoxemia. And so this is a good point for me to, good place for me to stop and just say, remember, oxygenation is different than getting rid of CO2, what we call ventilation. So CO2 and oxygen should be very separate in your mind when you're talking about pulmonary physiology, because then it allows you to separate the different pathophysiologic mechanisms as well. What's important for us to know is that high altitude is going to affect pulmonary blood flow. And in particular, because you are going to have hypoxemia, you're going to have high pulmonary resistance. And because your alveolar O2 is going to be low, you're also going to have vasoconstriction of the pulmonary vasculature. What does this do? Well, this over time causes hypertrophy of the right ventricle, and it can lead to cor pulmonale. And then finally, we talked about how high altitude can affect the hemoglobin oxygen dissociation curve. And this can be highly tested on your USMLE. In fact, what you have to know is that the upregulation of 2,3-BPG shifts the curve to the right, offloads oxygen from the hemoglobin. Remember that if you have a right shift in your hemoglobin oxygen dissociation curve, you increase the P50 and you thus decrease affinity for oxygen. Let's do a little bit of a physiology integration now. Where are the peripheral chemoreceptors located in your body? Well, they are located at the carotid body and the aortic arch. Now remember, these are chemoreceptors. They are different than baroreceptors. They're in the similar location, but chemoreceptors, they are going to respond to chemical changes in the blood. Now, there are some cranial nerves that are very important for us to integrate with the chemoreceptors, and that is 9 and 10. And what cranial nerves 9 and 10 serve as are afferent signals to the brain. The major stimuli for the peripheral chemoreceptors are actually going to be a low P(a)O2. And I can't stress that enough. A low P(a)O2 is going to stimulate the peripheral chemoreceptors. The central chemoreceptors, which are found in the brain, they are going to be more sensitive to acidosis, whereas the peripheral chemoreceptors, they are going to be more sensitive to hypoxemia. So why this 60 to 80 P little AO2? Well, that is where the hemoglobin saturation of oxygen drops at a very fast rate. As you know, this is a somewhat sigmoidal curve when you're talking about your hemoglobin oxygen dissociation curve. And when you are at 60 to 80, you have a very exponential decrease in your hemoglobin oxygen dissociation curve. So one of the questions and pathophysiologic mechanisms that I want to go through is how hypoxemia led to that increased hematocrit. Remember that hypoxemia due to high altitude, and what was the reason why you have hypoxemia? Your atmospheric oxygen is low, and or partial pressure of oxygen at that high altitude is low, and thus your P big AO2, alveolar O2, is going to be low as well. Subsequently, you have low oxygen delivery to the kidneys because of the hypoxemia. And then finally, the kidneys are going to start secreting increased EPO, and that gives you a high RBC mass and a high hematocrit. Now, when you see a high hematocrit, one of the differentials on your USMLE you will think of is going to be polycythemia vera. And in polycythemia vera, remember that you are actually going to have a low EPO. And the reason why is because P vera is going to be an increase in JAK-STAT, which is a pathway that starts proliferating relatively all cell lines. And what the classic test question you will see is not only a high hematocrit, but this classic itchiness due to the increased cell turnover. And that itchiness is after, for example, a hot shower. Another important vignette for us to integrate here is going to be the one of obstructive sleep apnea. Now, this is going to be the similar pathophysiology here, because remember, when you have obstructive sleep apnea, as we will talk about, you get a VQ mismatch that leads to hypoxemia. And hey, you can follow the same pathophysiologic progression. Hypoxemia causes low oxygen delivery to the kidneys, and thus subsequently you get an increased EPO. And so what's important for us to recognize is that OSA on our USMLE questions will have a patient who has a BMI of greater than 30, has headaches, and is going to have daytime sleepiness as well. All right, so we talked about the causes of normal AA gradient hypoxemia. Let's go ahead and talk about high AA gradient hypoxemia. Now, the key concept here is that you have a disruption of the pulmonary capillary interface. I can't stress that enough. A 45-year-old male is hospitalized for hypoxemia. The patient has a history of smoking. He is noted to have increased sputum production. His pulse oximetry is noted to be low, cluing you in to hypoxemia. He has increased work of breathing on exam, as well as respiratory distress. He breathes with pursed lips and has a copious, purulent cough. Which of the following mechanisms is the primary cause of hypoxemia here? All right, so this patient has a COPD exacerbation. And in particular, you're seeing that his bronchitis is really bad. Go ahead and put in the chat what you think the answer is that is causing the hypoxemia here. All right, we're having a lot of good answers in the chat. And if you said VQ mismatch, you are going to be right. Remember that your mucus plugging actually is going to cause you to have an obstruction of the alveoli. And the obstruction of the alveoli is going to decrease your ventilation and also is going to affect your perfusion by a secondary mechanism. And the mismatch between ventilation and perfusion is known as VQ mismatch. And this is a cause of hypoxemia. Let's go into VQ mismatch questions a little bit more. We have a 45-year-old male who has a motor vehicle accident and suffers a right femoral shaft fracture. He has a surgery, and 3 days post-operatively, he presents with tachycardia, tachypnea, and pleuritic chest pain. So he's really sick. He is hypoxemic and has a rash that is shown right here. CT shows blockage of pulmonary artery flow. What is the likely cause of the patient's hypoxemia? Go ahead and put it into the chat. What do you think is the diagnosis? And many people in the chat are putting in PE, and you're absolutely correct. And this is particularly one of those fat emboli. And the fat emboli are going to have this characteristic petechial rash on the chest. And if you take a histology of the pulmonary artery sample, what you will notice is that there are lipid inclusions in that pulmonary artery, and that represents the bone marrow having a high lipid content. Now, this is going to be an extreme of VQ mismatch. And that is that if this is the alveoli and this is the capillary, and we said that in PE, you are going to get an obstruction of that capillary, this alveoli is quote unquote dead. It can't participate in gas exchange. So one of the extremes of VQ mismatch is known as dead space. And we're going to go into that a little bit more. What's important for us to know in this case of VQ mismatch and all cases of VQ mismatch, because the pulmonary capillary interface is compromised, you're going to have an elevated AA gradient and the specific diagnosis I talked to you about. So now let's go into two extremes of VQ mismatch, and that is shunt and dead space. Now, remember, shunt is that bronchitis patient who had that mucus plugging. And in this scenario, you have no ventilation, and thus your V to Q ratio is 0. So what are some USMLE questions that are going to be relevant here? Well, you're going to be thinking about the COPD patient who makes a lot of mucus, a foreign body. Remember that foreign bodies are going to preferentially go to the right lobe because of its anatomic configuration. And obstructive sleep apnea, you are going to get a collapse of the alveolar wall, causing you to have a compromise in your V, in the V to Q ratio. Subsequently, you're going to be talking about dead space. And in dead space, you're going to be thinking about blocking of the pulmonary artery that is going to be right on that alveolar surface. And when you have a 0 in the denominator, the V to Q ratio is going to approach infinity. Think about the pathophysiologic mechanism as a blockage of the pulmonary artery or downstream the pulmonary capillary. And the classic example of this is a pulmonary embolism. So when you block that vessel, like I said, that alveoli is dead. So shunt and dead space, two extremes of VQ mismatch, and it's under the auspices of elevated AA gradient hypoxemia. Now, here is one of the key test-taking strategies. Anytime on the USMLE, I see tachypnea and tachycardia, i.e. in the vital signs, I see a high respiratory rate, high heart rate, I think about PE. I just pay my respects for pulmonary embolism because those questions can really sneak up on you. So one of the key things that I'm going to be talking about is this whole concept of shunting. Now, just as a review, in shunting, is your V going to be high or is your V going to be low? Go ahead and put that in the chat. Your actual V in the numerator, is it going to be high or low in shunting? And people are saying low, and you're absolutely correct. Remember, a shunt is going to be where your alveoli are plugged up, your V is equal to 0, but your perfusion is still there. So when you have a blockage of the alveoli, you have no V in the V to Q ratio, and thus you are going to have a low P big AO2. So right here, your P big AO2 is going to be low. And subsequently, what you are going to notice is that the capillary, which is going to be right here that I'm going to highlight in yellow, is going to shunt the blood flow to better ventilated alveoli. And the reason why is because the lung has a unique property called hypoxic vasoconstriction. And that is essentially going to be if the alveoli itself has a poor P big AO2, well, then the capillary is going to say, I'm going to shunt to an area of the lung that is better ventilated. It's basically like me saying that if I'm a capillary and my neighbors upstairs are making a lot of noise and are hypoxemic, I'm going to then shunt to another apartment, find somewhere else because my actual alveolus is messed up. So that increased pulmonic vasoconstriction is due to a high cytosolic calcium. And that's an exam question as well. Remember that calcium is going to be one of your powerful vasoconstrictors. This is going to be a graphical representation of what I was just talking about, the shunt and hypoxemic vasoconstriction. What you notice here is that this hypoxic vasoconstriction is going to shunt blood into more normal areas. So this is an important concept, guys, and that is talking about regional circulation. Let's just quickly go through the table, and we're going to be going through some important USMLE vignettes. But just so that I know you're paying attention, go ahead and type in yes into the chat if you can still hear me, see me, and you're active and engaged. Awesome. Heba, Jamie, Livia, Daniel, Bianca. Wow, we have so many people still staying active and engaged. Let's do this. So as you can see in the headings of this table, you see circulation, you see factors that increase blood flow to these areas, and the USMLE vignettes. Let's go through this first vignette. A patient who presents with a myocardial infarction goes to the cath lab and gets a stent placed. What local metabolite mediated flow prior to the stent? Well, what increases the actual blood flow in the coronary circulation is hypoxia, as well as adenosine. And remember, adenosine is really powerful because essentially it represents low ATP states. Let's go through this question. A patient who has a history of asthma has respiratory acidosis and is somnolent. What is the mechanism? Or how about this one? A patient with impending herniation. What is the mechanism behind hyperventilation? In those cases, you're really getting the concept that CO2 is very tightly regulated the cerebral circulation. And what you have to know is that a high CO2 causes you to have increased cerebral perfusion. And a low CO2 is going to cause you to vasoconstrict your cerebral vasculature. An athlete who feels sore the next day, what mediator contributes to a soreness? Well, think about it like this. If you have high lactate and high adenosine, aren't you going to have an increase in blood flow to the skeletal muscle? You're absolutely correct. And let's go ahead and do a little bit of autonomic tie-in here. What is the receptor that's going to be active? That's going to be the beta-2 receptor, because remember, beta-2 found in the skeletal muscle causes you to vasodilate. We talked about in the pulmonary vasculature how patients with obstructive sleep apnea presenting with daytime sleepiness are going to have obstruction of their alveoli. They're going to get alveolar hypoxia or low P big AO2, and subsequently that is going to affect blood flow. And finally, we recognize that if you have increased amounts of prostaglandins, you're going to dilate your afferent arteriole. So let's talk a little bit about this vignette, which is commonly tested. A female with osteoarthritis who has taken ibuprofen for the last 5 months, which is an NSAID, now has elevated creatinine. What is the mechanism? Well, we know that NSAIDs are going to modulate the cyclooxygenase pathway. You have low PGE2. And if you have low PGE2, you're going to have afferent arteriolar constriction and subsequently impaired clearance of creatinine. All right. So with all of this hypoxemia talk and hypoxic vasoconstriction, let's do a little bit of a cardiology integration. What would chronic hypoxic vasoconstriction do to right ventricular afterload? Go ahead and type in up or down into the chat box. Chronic hypoxic vasoconstriction to right ventricular afterload. Heba, David, Mark, Santiago, everybody is saying up, and you're absolutely correct. That if you have a high level of hypoxic vasoconstriction, you're going to increase pulmonary vascular resistance, and that is going to cause you to have increased right ventricular afterload. So in order for us to illustrate that, we recognize here that in your pulmonary arteries, you have increased pulmonary vascular resistance due to vasoconstriction, and that is going to cause your right ventricle a increased resistance and an increased amounts of strain, and the RV is then going to have the RV is going to have increased amounts of afterload. And subsequently, if the RV is going to fail, it can back up into the RA, and then it can back up into the SVC and IVC. Well, if it backs up into the SVC, you're going to get JVD on exam. And if it backs up into the IVC and lower, you're going to get hepatomegaly and peripheral edema. And these are signs of right heart failure. So what is afterload? Well, afterload is the pressure the heart must work against during systole. High PVR, high right ventricular afterload. So what are some USMLE questions on right heart failure? Well, it's simply going to be this. A patient with long-standing OSA presents with shortness of breath, no murmurs, JVD, hepatomegaly. But what's key, guys, in right heart failure is the lung sounds are clear. And why did I put no murmurs? Well, that's a pertinent negative to rule out valvular heart disease as a cause of right heart failure. And this is due to the long-standing OSA. So VQ mismatch, very high yield. And I just want to summarize it by talking or revisiting this pulmonary capillary interface where you see the blockage of the alveoli, that's going to be shunt. And if you have blockage of the actual capillary, which is going to be right here, that's going to be known as dead space. Let's go ahead and continue to move on and talk about this vignette here. A 62-year-old male comes to the clinic due to a 6-month history of progressive exertional dyspnea. He has no environmental exposures. The patient dies of respiratory failure. Autopsy findings are notable for heterogeneous lung parenchyma with predominantly subpleural areas of dense collagen deposition, lymphocyte infiltration, and fibroblast proliferation. Which of the following is the most likely diagnosis? A, alpha-1 antitrypsin, B, chronic bronchitis, C, asbestosis, D, IPF, or E, hypersensitivity pneumonitis. What do you guys think? Put it in the chat. Excellent. We have a lot of people saying D, and you're absolutely correct. Remember that anybody who presents with this progressive, long-standing history of shortness of breath, you should really think about fibrosis. And this gross pathology hallmark really defines fibrosis. So let's go ahead and go through this a little bit more because fibrosis is going to be a classic example of diffusion limitation causing hypoxemia. And remember, diffusion limitation is going to be a cause of hypoxemia. And what is going to be the AA gradient? Well, the AA gradient is going to be elevated. So this is just yet another subtype. What you notice here is that in fibrosis, you have a thickened alveolar capillary membrane, and that impairs P big AO2 from going into P little AO2. This relates to Fick's law of diffusion, in which if you have a high thickness of the membrane, i.e. fibrosis, you're going to have decreased diffusion. Subsequently, when patients are going to have fibrosis of their small alveoli, you actually are going to have increased radial traction in your proximal airways. Think about the fibrosis stenting this airway open. And so USMLE loves to go for this concept. And that is that the high radial traction on the proximal airways in the setting of fibrosis causes high peak expiratory flows because now you have an increased caliber for the air to flow out of. Finally, we're going to be talking about right to left shunt. And in right to left shunt, the key concept is that blue blood here, P little AO2 less than 40, goes into the systemic circulation. And you notice that now the P little AO2 is going to be in the systemic circulation and has bypassed the lungs. A 5-year-old boy is brought to the office due to intermittent episodes of blueness. He was adopted and his medical records are unknown. The boy assumes a squatting position to mitigate his blue episodes. Physical exam reveals a prominent right ventricular impulse and a harsh systolic murmur. Which of the following embryological events is the most likely mechanism that caused this patient's condition? All right. So before we get into the answer choices, what do you think the diagnosis is? The squatting position, intermittent cyanosis? Everybody is saying tetralogy of Fallot, and you're absolutely correct. So tetralogy of Fallot is actually going to be due to a abnormal neural crest migration, and that ends up causing deviation of the infundibular septum. Now, it's easy for us to memorize the 4 things in tetralogy of Fallot, but I think we should spend some time understanding it. And then you also want to just quickly make that integration or that jump into the fact that when you have a patient with tetralogy of Fallot, you should be thinking of other syndromes associated with it. And one of the key syndromes is going to be DiGeorge syndrome. And this is always tested, that DiGeorge syndrome is going to not only have tetralogy of Fallot, but it's going to have hypocalcemia due to a lack of parathyroid development. And remember, DiGeorge syndrome is going to be an abnormality in the 3rd and 4th pharyngeal pouches. So with this in mind, let's go ahead and go into tetralogy of Fallot. Real quick, what happens is that you have this overriding aorta and this abnormal infundibular migration. Once you have the overriding aorta, what happens is that you end up pushing all of the tissue and blocking the right ventricular outflow tract, and thus having a stenotic pulmonary valve. So as you have the abnormal neural crest migration, you're going to have the pushing into the right ventricular outflow tract, and you're going to expose a VSD. And when you expose that VSD, you are going to then have now a gateway for more right to left shunting. And why is that? Well, the pulmonic stenosis causes right ventricular hypertrophy, and you have now a right to left shunt. And what does that cause? Hypoxemia. It bypasses the lungs, and thus you have an elevated AA gradient. All right, guys, let's go ahead and talk about our next portion of this lecture, and that is going to be physical exam findings related to the respiratory exam. But if you guys are learning a lot and you are continually energized to keep focusing here, go ahead and put in yes into the chat box. Awesome. We have a lot of people that are just going nuts here, and I absolutely love it. Thank you so much for tuning in and being active and engaged. So let me go through some physical exam findings when it comes to USMLE vignettes. And what I first wanted to call your attention to is the fact that USMLE questions will have the physical exam findings usually after the vital signs and before the labs. And this is where I want to highlight this concept that you should know the anatomy of the vignette. Remember, it goes chief complaints, supporting symptoms. You're going to get vital signs, then the physical exam, labs and imaging, and then they'll ask you, hey, what's the most likely diagnosis, etc. So the more you understand how a vignette is written, the increased comfort you'll get in answering NBME questions. That's why my whole tagline to HyGuru is think like the test maker. And I'm very passionate about test taking strategies. And that's why I created a whole course just focused on test taking strategies. And so as you can see here, they give some supporting symptoms. This is directly from the free 120. In this question, they didn't give any vital signs, but definitely they highlight the physical exam here. Physical exam shows, and then that is right before here in pink, laboratory studies. So just understanding how a vignette is written and the various components allows you to even know where to look for relevant data. Here is the quick and dirty on how I think about the lung exam for the USMLE. Tactile fremitus essentially is me putting my hands right on the back of the chest. And if there is going to be a solid medium, i.e. some sort of consolidation like pneumonia, you're going to get increased vibrations on your hands. Percussion is going to essentially be dull when you're going to have solid or liquid mediums. For example, like a pleural effusion, if you are going to start tapping on the back, you're going to have a dullness to percussion. Whereas if there is going to be air in the actual thoracic space, you're going to get a hyperresonance to percussion. And just the quick and dirty for the USMLE guys, if you see hyperresonance to percussion, you're going to be thinking about a pneumothorax. Breath sounds are usually decreased in some of your most common USMLE scenarios. And I always think of crackles, or it's also known as rales, representing fluid or fibrosis in the alveoli. And what can fluid or fibrosis in the alveoli cause? Well, hey, hypoxemia. It can cause you to have a VQ mismatch, or it can cause you to have a diffusion impairment. A 72-year-old woman comes to the physician because of a 3-day history of fever, shortness of breath, difficulty swallowing, chest pain, and cough. She is frail. Physical exam shows tachypnea and equal pulses bilaterally. Percussion of the chest shows dullness over the right lower lung field. Laboratory studies show arterial hypoxemia, decreased PCO2, which you can really correlate to the tachypnea that you see in the test question, and a chest X-ray showing an area of opacification in the lower region of the right lung. Which of the following is the most likely cause of this patient's condition? And this is directly from the free 120. So you see that the patient has a right lower lung consolidation, and that's why you see the dullness to percussion. And this is an elderly female who may have some sort of an aspiration risk because of the cough, and that is why B is going to be the correct answer. So let's do a little bit of an anatomy integration. Think aspiration pneumonia in the following patients on the USMLE. And I just posted about this on Reddit yesterday. And I really, just as an aside, I'm just so pumped when I get to interact with people in Reddit and over email, et cetera. So, if you have questions that come up throughout your preparation and you just need a little bit more extra help, feel free to just reach out to me and I'd be happy to respond to and clarify some concepts. But when you're thinking about aspiration, you want to be thinking about patients on your USMLE who have altered consciousness. For example, those patients with dementia or those patients who have a drug intoxication. You also want to be thinking about patients who have neurological deficits, such as strokes or demyelinating conditions, as well as patients who have really, really big stomachs. And if they have underlying GERD, guess what? Whoop, the actual food or liquid contents end up going up the esophagus and then into the trachea, and that's why you have the aspiration. Now, what's high yield for us to know is that why is aspiration going to be more seen on the right side? Well, it's because the right mainstem bronchus is actually going to be wider and more vertically oriented. And the USMLE really likes for you to know that. Remember that typically it's going to be in the right lower lobe. However, it depends on whether you're going to be standing or supine when you have aspiration. An 18-year-old male presents with sudden onset of chest pain. He recently was at a football game with his friends. He has smoked a pack of cigarettes daily, and he has pain worse on inspiration. I want to pause right here. Pain worse on inspiration, that's called a pleuritic chest pain, very high yield. His respiratory rate is elevated, and physical exam shows a tall, thin patient in acute distress. He has low oxygen levels. The trachea is midline, and there are decreased breath sounds and hyperresonance to percussion on the right lung field. Which of the following mechanisms best explains this patient's symptoms? A, apical subpleural bleb rupture, B, hyperinflation and air trapping, C, pan-acinar emphysema, or D, trauma leading to a tension pneumothorax. And people are putting in A, and you're absolutely correct. The rupture of the apical bleb, I can't stress that enough, because that causes those spontaneous pneumothoraces. Remember, the trachea being midline or shifted towards the side of the lesion is key for spontaneous pneumothoraces, whereas tension pneumothoraces here, they're going to have tracheal deviation to the opposite side. So let's just compare and contrast spontaneous versus tension pneumothoraces. A spontaneous pneumothoraces, typically patients present with shortness of breath. We talked about the tracheal deviation, and think about this in patients who are these tall, thin males who have maybe a pre-existing lung condition, or if you have very high yield Marfan's type habitus or Ehlers-Danlos. These are connective tissue diseases. So what vignettes on the USMLE are going to have Marfanoid habitus? Well, the first one being if you have Marfan syndrome, fibrillin 1 mutation, but you're going to be thinking about that in MEN2B syndromes. You're going to be thinking about that also in homocystinuria. Let's contrast spontaneous pneumothoraces from tension pneumothoraces. And tension pneumothoraces, you're going to be thinking more related to trauma. And as you then have very high yield, a positive intrapleural pressure, you're going to have tracheal deviation away from the lesion. And subsequently, your intrathoracic pressure is going to be very high. And I can't stress that enough because they love to test that a high intrathoracic pressure causes you to decrease left ventricular end diastolic volume, also known as preload. Both types of pneumothoraces are going to have decreased fremitus, decreased breath sounds, and most importantly, hyperresonance to percussion because it's an air-filled medium. All right, guys, the next portion of this is going to be restrictive versus obstructive lung disease. This is probably my number one test-taking concept. And that is the fact that anytime you have a pulmonary question, you should try to categorize the pathology into restrictive versus obstructive, because then that allows you to channel your mental models and your thoughts a little bit better. Let's talk about restrictive versus obstructive. In my opinion, restrictive lung disease is a problem with getting the air into your lungs. And if you have a problem with getting the air in, you're going to be breathing at low lung volumes. That's the tagline for restrictive lung disease. Obstructive lung disease, you are going to have a problem with getting the air out. And that's why we call obstructive lung disease as having the tendency to air trap. Because if you can't get the air out, you're going to continuously trap air within the alveoli. And that's why patients are going to be hyper expanded on their chest x-ray. A 35-year-old male is hospitalized for abnormal liver enzymes. He has a history of jaundice as a neonate. His past chart review shows a decreased FEV1 on spirometry. He is a lifetime non-smoker. Which of the following pathophysiologic mechanisms explains this patient's underlying condition? A, increased reactive oxygen species causing breakdown of lung elastin. B, decrease in lung defense mechanisms. C, decrease in proteases causing increase in lung compliance. Or D, decrease elastase activity. And so many people are putting D, and the answer actually is going to be B. The answer here is alpha-1 antitrypsin. And remember that alpha-1 antitrypsin disorder is going to affect both the liver as well as the lungs. And if you have low alpha-1 antitrypsin levels, you have an increase in your elastase. Because remember that alpha-1 antitrypsin is there to decrease neutrophil elastase. Low alpha-1 antitrypsin, you're going to have an increase in your neutrophil elastase. So this brings me up to the concept of centroacinar versus panacinar emphysema. In centroacinar emphysema, many of us know that it's related to a patient in your USMLE question that has smoking. And remember, smoking causes an increased amount of inflammatory cells to come into the lungs. And these inflammatory cells are going to have increased amounts of proteases. The high amount of proteases outweigh the levels of alpha-1 antitrypsin you have in centroacinar emphysema. And so the increased proteases are going to then start damaging the integrity of the lung. One of the highest yield proteases is going to be elastase, and elastase degrades elastin. If you have bad elastin, you don't have good lung recoil. And remember that elasticity and compliance are going to be in a balance. Compliance is the ability to fill the lung, whereas elasticity is going to be the ability to recoil back. So if you have low elasticity, you have a very high compliance. Your lung ends up being a very floppy bag, just like the left ventricle in congestive heart failure. A very compliant lung is going to further worsen your air trapping. And that's why emphysema is a obstructive lung disease. Pan-acinar emphysema is going to be a decrease in antiproteases. It's a decrease in alpha-1 antitrypsin. And typically, you are going to have involvement of the lung and the liver. In fact, alpha-1 antitrypsin deficiency can lead to cirrhosis because of the accumulation of these abnormal proteins within the hepatocytes. A 38-year-old female presents with shortness of breath. She has decreased exercise intolerance. She currently has a BMI of 41, a respiratory rate of 22, and physical exam is notable for central obesity. Which of the following spirometry changes would be most likely seen in this patient? A, decreased FRC, B, increased residual volume, C, decreased FEV1 to FVC ratio, D, high FEV1, or E, increased chest wall compliance. So as you can see, these questions are getting a little bit harder. And in this scenario, I'm going to be testing you on how obesity is going to affect your pulmonary mechanics. And what obesity can cause is going to be a restrictive lung disease. Because you have decreased chest wall compliance, you are going to start breathing at low lung volumes. And as a result, you are going to have a decreased amount of FRC, functional residual capacity. Now remember that a capacity is defined as 2 or more lung volumes. And I can't stress that enough. The capacity is going to be 2 or more lung volumes. And your functional residual capacity is your expiratory reserve volume plus your residual volume combined. That's important for us to recognize. Let's go ahead and now talk a little bit about FRC for the USMLE. That rhymes, right? I'm like a USMLE rapper. FRC for the USMLE. Here we go. So what is FRC? Well, FRC is going to be ERV plus RV. But I think what's really important is that FRC is right here. It is going to be at the end of resting tidal volume. End expiration of the tidal volume. That is FRC. I can't stress that enough. They can put a dot right there and say, what is that? And that's FRC. Remember that FRC is going to be where pulmonary vascular resistance is the lowest. Now, can you believe that can be a test question right here? Is that at FRC, you have the lowest pulmonary vascular resistance. And if you have low pulmonary vascular resistance, you're then going to have optimal right ventricular function, because then the right ventricle doesn't have to push across a high resistance circuit. And then finally, FRC is going to be the balance between the chest wall and the lung. Remember, ladies and gentlemen, that the chest wall wants to always recoil out and the lungs always want to recoil inward. And what balances that? That is going to be the FRC. The FRC balances the chest wall and the lungs. And so when you have hyper expansion of the lungs, such as an obstructive lung disease, your FRC has to increase. And that's why these patients have a barrel chest. So I just showed you a lot of graphs, and that's why I want to go through this USMLE test taking strategy. And that is that when I see graphs on the USMLE, I first say, Rahul, don't panic. Second, I say, define what are the X and Y axes. And then third thing I say is establish trends. So here's a good example. Number 1, don't panic. Number 2, define the x-axis, which is going to be volume, and the y-axis is going to be inspiration and expiration. You notice here that the trend is that you are breathing at higher lung volumes in the red, so that is going to be obstructive lung disease, And when your flow volume loop is going to be shifted to the right, i.e., you are going to be breathing at lower lung volumes, you are going to have a more restrictive lung disease. All right. So here's going to be a rapid USMLE vignette review on obstructive versus restrictive. A smoker with increased productive cough and a chest x-ray showing flattened diaphragms, that should make you think of obstructive lung disease and specifically COPD. COPD is categorized by bronchitis and emphysema. And remember, bronchitis is a hyperplasia of the submucosal glands. A child with cough, itchy, scaly rash, which is kind of due to atopic dermatitis, rhinitis, and lab showing high IgE, which is related to atopy. This is going to be asthma, and that's an obstructive lung disease. Remember that asthma is going to be due to bronchial hyperresponsiveness, and you're going to integrate beta-2 agonism because that not only is at the level of your vascular smooth muscle and your muscles, which we talked about, but also it's going to be in the airway. A child with fatty stools and poor growth with foul-smelling sputum and CT showing bronchial, large airway dilation, you're going to be thinking about cystic fibrosis and in particular bronchiectasis. Now remember that bronchiectasis, they can easily give you a CT scan that shows this peribronchial mucus cuffing and thickening. Real quick, let's go ahead and talk about asthma. Please go ahead and disregard that. Asthma in the pathophysiology has an early phase and a late phase. The key points here is that the early phase of asthma is similar to anaphylaxis, in which IgE binds on mast cells just like a type 1 hypersensitivity reaction, and you have dumping of histamine granules. In the second phase of asthma, you have more leukotrienes, and you have leukotriene C4, D4, and E4 perpetuating your bronchoconstriction. This is where steroids really start playing a role because you're going to decrease the amount of inflammation. And remember, just as a tie-in, it's not pictured here, but what does LTB4 do? That recruits neutrophils, very high yield for us to know. Eosinophils have MBP, which is going to perpetuate bronchoconstriction as well. And remember, eosinophils are going to be induced by IL-4 and IL-5. Very important for us to recognize here. All right, let's keep going on with restrictive and obstructive. A patient with progressive shortness of breath and history of radiation, or they put history of having bleomycin, or bilateral lymphadenopathy, which is related to sarcoid, or honeycombing on CT. What am I going for here? This is going to be interstitial lung disease. And remember, that causes hypoxemia due to diffusion defect. It's a restrictive lung disease. And just to integrate some key points, IL-10 and TGF-beta increase fibrosis of the lungs. If you cut out the type 2 pneumocytes, such as if you're on bleomycin therapy, for example, you have no stem cells and you have more fibrosis. A patient with weakness worse at the end of the day, the patient also has cranial nerve problems and low peak expiratory flows. So bulbar symptoms with weakness that is going to be worse at the end of the day, you're going to be thinking about myasthenia gravis. And this is essentially a syndrome that is going to give you respiratory muscle weakness, and thus you are going to be breathing at low lung volumes. Just as an anatomy tie-in, external intercostals help with inspiration, internal intercostals help with expiration. They're opposite, and the USMLE loves to test that. And we know that C3, C4, C5 keeps the diaphragm alive. Finally, we're going to be talking about a patient with obesity or scoliosis. We already talked about this question, but remember that thoracic deformities can cause a restrictive lung disease. And in restrictive lung disease in general, you have a normal to slightly increased FEV1 to FVC ratio, and that is primarily because your FVC tanks more than your FEV1. All right, guys, we have two more topics that we're going to cover in the next 10 minutes. Lung tumors, followed by respiratory distress syndrome. Let's go ahead and talk about lung tumors. When I think about lung tumors, here's how I recognize it on USMLE questions. USMLE questions will have presentations related to constitutional symptoms. They'll have essentially weight loss, They'll have this chronic cough that may have bloody sputum. They may also present your lung tumor questions with paraneoplastic syndromes, and these have very important physiology and electrolyte tie-ins. A 59-year-old male presents with right scapular pain. He is also feeling numb in his fourth and fifth fingers in his right arm. He has had cough with no sputum, so a dry cough. He's had weight loss, and he's had occasional night sweats. Travel history is insignificant, so it's not tuberculosis. And he is a 2-pack year smoker. Physical exam is notable for orbital puffiness. Ooh. Which of the following is the most likely etiology for these patients' symptoms? Airway obstruction, superior sulcus tumor, pleural effusion, or pericardial effusion? And I'm seeing a lot of B in the answer choices, and you're absolutely correct. That with the brachial plexus involvement and the fact that you're having orbital puffiness due to decreased venous drainage, you're going to be thinking about your superior sulcus tumor causing this SVC type syndrome. So that kicks us off into cancers. The first cancer we'll talk about is small cell lung cancer. A 73-year-old smoker comes in with a dry cough and weight loss, as you can see, constitutional symptoms. He is found to have a large lung mass on imaging and a tumor with high mitotic count and increased N to C ratio. His serum sodium levels are low. What is the likely stain which will be positive in this patient's oncological lesion? So in this scenario, we're talking about small cell lung cancer, which is a small round blue cell tumor. And remember that these small round blue cell tumors are neuroendocrine in origin. And one of the common stains that are positive in small cell lung cancers is chromogranin. So this helps me integrate the various tumors on the USMLE that are small round blue cell tumors that are derived from neural crest or neuroendocrine. Let's go ahead and go through them. Rhabdomyosarcoma, which is going to be desmin positive. Remember, you can have rhabdomyosarcoma of the vulva and vaginal area. That typically is going to be in little babies with the grape-like mass that is coming out of the genitalia. Ewing sarcoma, which is going to have that onion skin appearance on your histology. Small cell lung cancer, which is going to have low sodium because of SIADH. Remember that ADH causes an increase in aquaporins. You increase your free water reabsorption, and that decreases your sodium levels. Carcinoid tumors are also small round blue cell tumors. They're going to have increased amounts of serotonin and breakdown products. Neuroblastoma, which is going to be a tumor of the sympathetic chain, typically seen in kids. You're going to have a high NMYC expression. And then melanoma, which is going to be S100 positive. But ladies and gentlemen, this is the beauty of how we go through material, and that is integrating across domains. We went through physiology. We went through a little bit of GenPath. We went through some oncology. I want you to learn in this integrative way so that all of the content that you're highly tested on sticks in your brain. All right, real quick, going through tumors, small cell lung cancer. Remember, it's neuroendocrine and etiology. Typically, it's going to be in a smoker. It's going to be central in the lung. And specifically, you'll have the SIADH presentation, the patient who presents with Cushing's. Tune into my endocrine lecture for that high-yield vignette. But remember the centripetal obesity, the striae, the proximal muscle weakness. Lambert-Eaton syndrome, which is going to be antibodies to voltage-gated calcium channels. Remember that that's different in presentation to myasthenia gravis. Myasthenia gravis, what are you going to have? You're going to have weakness that is going to worsen with activity. Lambert-Eaton, the weakness improves with activity. Squamous cell lung cancer is going to have squamous etiologies, i.e. intercellular bridges, as well as keratin pearls. And this picture shows you the intercellular bridges between the cells. This is also seen in a smoker, centrally in entity, and you are going to think about PTHRP, which is going to be parathyroid-related peptide. That causes hypercalcemia. And remember, your endogenous PTH levels are actually going to go down because you're so hypercalcemic. What do intercellular bridges represent desmosomal connections. Where else are you going to be integrating desmosomal connections? You're going to be integrating that in your pemphigus vulgaris. Very high yield for us to know. Adenocarcinoma, not as high yield, but what's important is that typically this is seen in non-smokers, and these tumors are going to act as peripheral consolidations, just similar to pneumonia. And they have these dysplastic cells, which means that it's a cancer, and an abundant clear cytoplasm, which is directly related to the amount of mucin that these tumors have. All right, ladies and gentlemen, this is going to be our last concept of the day, and that is talking about acute respiratory distress syndrome. If you guys are enjoying what you are seeing right now, go ahead and type in yes into the chat box. Minnie is, Mark, Nana, Jessica, I got some smiley faces. I really appreciate that. That keeps me going. I feed off of your guys' energy. Let's go ahead and go through our last concept, and that is acute respiratory distress syndrome. A patient is admitted for pancreatitis. He has a history of alcohol use. He is noted to have mild respiratory distress on admission. And on day 3 of hospitalization, he develops hypoxemia and is transferred to the intensive care unit. He is intubated, and chest x-ray reveals new bilateral pulmonary opacities. Which of the following parameters is most likely to be normal in this patient? A, capillary permeability. B, work of breathing. C, VQ ratio. D, lung compliance. E, pulmonary capillary wedge pressure. All right. So pancreatitis leading to this bad, nasty lung condition, and that is ARDS. And remember that ARDS, it is strictly the lung. The opacities are strictly the lung and not the heart. So you are going to have a normal left atrial pressure. Let's go ahead and go into that a little bit more. So acute respiratory distress syndrome, you're going to be looking for a trigger in your test question, and that is pancreatitis, trauma, infection. You're going to be thinking about the release of inflammatory cytokines, for example, IL-1, TNF alpha, that causes pulmonary vasodilation, but you're also going to have this neutrophil migration. And when you have pulmonary capillary vasodilation and neutrophil migration, you're going to start having a lot of effusions in the lung. The actual inflammation is going to cause high reactive oxygen species, and that's going to cause lipid peroxidation, and you're going to start damaging the alveolar capillary interface. And so remember, just going back to Gen Path, ARDS gives you an exudative effusion. This alveolar hyaline membrane is going to have this exudative effusion, and that is characterized by high LDH, which is related to increased cell injury, and high protein levels as well. And that's different than transudative. Finally, what you got to know is that because you have pulmonary capillary vasodilation, that causes a washout of surfactant. And when you have a washout of surfactant, your lung compliance really just tanks. So pulmonary washout and exudative effusion causing a high interstitial barrier as well as VQ mismatch, very important pathophysiologic mechanisms at play in ARDS. So the key in ARDS is to have new infiltrates on chest x-ray, but when you see these bilateral infiltrates, you're going to be like, why can't that be due to heart failure? Well, if you're going to isolate ARDS as the diagnosis, you're going to be making sure that there's no cardiogenic causes. And so your LA pressure, your pulmonary capillary wedge pressure, is going to be normal in ARDS. Very high yield for us to know. And a normal pulmonary capillary wedge pressure is anything around less than 12 to 15. Last question of the day. A 24-hour neonate presents to the neonatal ICU for tachypnea and hypoxia. The patient was born at 32 weeks to a mother who had type 2 diabetes. Prenatal ultrasounds were notable for polyhydramnios. Makes sense. Mom had diabetes. The patient was delivered via C-section. On exam, patient has perioral cyanosis, a mild murmur at the infraclavicular border with a rumbling sound. That sounds like a PDA to me. Which of the following pathophysiologic mechanisms describe this patient's clinical state? A, uncontrolled pulmonary artery smooth muscle proliferation. B, left to right cardiac shunting. C, increased alveolar wall surface tension. Or D, oligohydramnios leading to low surfactant. So the answer here is going to be C, increase alveolar wall surface tension. The keys to this question are the fact that the patient is premature, the mom had high amount of insulin resistance, which caused decreased surfactant production. There was a lack of glucocorticoid stress because the patient had a C-section and the baby was then delivered without that increased glucocorticoid stress. Remember, glucocorticoids actually stimulate surfactant synthesis. And so all of these are going to cause hypoxemia because the alveoli are starting to collapse because there's no surfactant. So neonatal respiratory distress syndrome, think about these risk factors in your test questions. The patients are going to have diffuse atelectasis, no surfactant. Those itty bitty grape-like alveoli can't stay open. And thus you have low lung volumes and these ground glass opacities, which represents alveolar atelectasis. And then all the air goes centrally and you see the bronchi, which have a nice histologically high cartilaginous structure, right? The air bronchograms are going to show up. Surfactant key take-home principles. Remember, lung maturity is going to start at 28 and end at around 32, 33 weeks. Surfactant is made up of lecithin, which is dipalmitoyl phosphatidylcholine, and it is made from the type 2 pneumocyte. So in closing today, key test-taking pearls for respiratory. For respiratory questions on the USMLE, categorize restrictive versus obstructive, integrate physiology concepts with pathology presentations, take the pathology, jump back into the physiology, and understand that there's an interaction between the lungs as well as the pressures in the heart. I do want you guys to stick around just for 1 second for my special announcement. And that is that in mid-May, May 15th through the 16th, I'm going to be hosting one of my very few paid webinars, and that is going through a rapid review of pharmacology. Ladies and gentlemen, what I want to do is I want to focus on pharmacological mechanisms, which are going to be so high yield for your USMLE exam. Guys, look at this. Pharmacology is about 20% of the USMLE. And now the USMLE step 1 questions are getting away from next best step in management and just testing you on the pharmacological mechanisms and the high yield side effects. So I'm going to take concepts from Sketchy and Pathoma, put them together, and I'm going to teach it from a more pathophysiology and physiology way so that you can really be optimized for test day. I hope that you can sign up with me. Go ahead and just click this link in the chat box so that you have the link to sign up. And if you have any questions, please make sure that you reach out to me and email me. I'm going to be using a reverse pyramid approach for pharmacology, starting with the big picture and then narrowing down so we can actually understand the drug mechanisms and the drug names themselves. But most importantly, I really thank you for joining me today for this webinar, spending your morning with me. I hope this was of value for you. And I have so many social media channels now. Thanks so much to my team for helping me as I create content. But I, again, really would encourage you to reach out if you have any questions. Before you leave, I would encourage you type one thing in the chat box that you learned today that you found very awesome, high yield, that you are going to now integrate. Go ahead, before you leave, type one thing that you learned, and I will be here for any questions that you have. I'm going to stick around for about 5-7 minutes after this webinar. All right. I'm going to be looking for what you guys learned. All right.